Welcome to ICAAC Live. If you're following us on Twitter, go to #@ICAAC. I'm Michael Schmidt. I'm one of the moderators of This Week in Microbiology, and it's my great pleasure to welcome you to ICAAC, the Interscience Conference on Chemotherapy and Antimicrobial Agents. I may have gotten that backwards, but ICAAC is sort of a mouthful. This week, we're going to explore the cutting edge of antimicrobial therapy and infectious diseases. Today I have with me the two program chairs, Craig Rubens from Seattle and Patel from Mayo and Rochester. And these two individuals had the hard task, along with their program committee, to really find the cutting edge in our respective disciplines. So they're going to share with us the must-see events that we need to take a look at here at ICAAC. So Craig, what's the must-see event for Tuesday?
So as I'll refer to my cheat sheet here because there's a lot of really good stuff going on. There's a lot of work of interest in how cancer chemotherapy affects basically the microbiome or the microbial flora of any person under therapy, and how that influences both their disease, their reaction to therapy, and also whether or not those changes could predict complications of therapy like diarrhea. So I'm assuming, Mike, you'd like us to go through this list and kind of talk about it a little bit? Or?
We'll look at it from the perspective of those individuals who are attending this conference for the first time. Yeah. The residents and the fellows that are, you know, the next generation of our discipline who are going to be at the cutting edge. If you had to tell them what would be the one plenary session they need to attend on Tuesday, you know, share with them. I think we all appreciate the importance of the microbiome, and we all understand about diarrhea because every human knows it when they see it.
Or have it.
Or have it.
Yeah. So anyway, one of the first ones that we'd recommend as a poster session today investigates what happens to the microbiome in cancer chemotherapy patients and what's called chemotherapy-induced diarrhea. And what these researchers found, Emmanuel Montassier, who's actually one of our program committee award winners, was that you could look at the microbiome in individuals who have a risk for diarrhea and predict 6 days in advance whether they would actually have a problem. So what this study is actually leading us to thinking is that there's ways we could look at the microbiome in cancer patients and potentially predict those that may have some kind of serious side effect like diarrhea.
Which will likely lead to new therapies before you undergo your chemo. Right. Thinking about in the future, we may actually have a probiotic that folks could take prior to undergoing the chemotherapy that could then prevent them from undergoing it. So it's really at the beginning of this cutting edge.
Does the potential implications of this abstract reach beyond just therapy as well as even new diagnostic approaches? So I think it's a revolutionary way of taking the new technologies that are out there to study things like the microbiome and then apply them to what we might otherwise consider sort of non-traditional infectious disease issues around cancer chemotherapy and other kinds of diseases.
Robin, we're going to go to you now and ask you, what's the one must-see event if you were advising your new fellow or infectious disease researcher?
Okay. Well, as you probably know, my background is in diagnostics, and there are a lot of new diagnostics that we have to use in our clinical microbiology laboratories today. That's exciting because it helps us provide better patient care, get patients on the right antibiotic or not on antibiotics in a faster time. And one that I wanted to highlight was a poster that's going to be presented today on rapid identification of what is in a positive blood culture bottle using what's called matrix-assisted laser desorption ionization time-of-flight mass spectrometry. It's a proteomic technique that literally just takes a few minutes to identify bacteria or fungi. And we're using it a lot directly off colonies in the laboratory, but this poster is going to talk about using it on positive blood culture bottles and the impact that that might make on patient care.
And it's got a really sexy acronym called MALDI-TOF.
Right.
And the other thing I find remarkable about this new emerging diagnostic technique is it's relatively inexpensive. So as we're all worrying about the ever-increasing cost of healthcare, MALDI-TOF offers us a great opportunity for advancing patient care, but at a reduced cost.
Right, at a reasonable price. And that's very important, you're right, because a lot of the new technology we look at is, unfortunately, very expensive. This one is fairly cost-effective. So
and it's
that's
fast.
Exciting, and fast. Yeah, accurate, fast, cost-effective, that's what we need.
Yeah. So Craig, go back to you now.
The next one? Okay. So there's a lot of interest in really in the diagnosis of bacteria as well as viruses and fungi on being able to diagnose quickly whether that particular strain or species that's causing an infection has certain antibiotic resistance genes. And there's been a lot
we
of,
just heard about that at the session you just came from.
That's right.
From Dr. Johnson.
Right. There's a lot of interest in being able to diagnose that rapidly. So while there's a strong emphasis on diagnosis of a bug that's causing a problem in a patient, whether or not it carries certain antibiotic or antimicrobial resistance genes is also critically important to clinical care. So there's been a lot of emphasis on new rapid tests, and there's a very interesting poster on new rapid tests for antibiotic resistance looking at extended spectrum beta-lactamase antibiotic resistance and being able to identify those that are resistant in a blood culture in 30 minutes. And so this is compared to the more traditional way that we culture and then put the microbe on a plate and test its antimicrobial sensitivity that can take 24 to 48 hours. So this poster is really interesting because it's really taking diagnosis of antibiotic and the ability to detect antibiotic resistance bacteria to a new level, faster, quicker, and earlier on in the culture of the organism.
And of course, this will have great impacts on patient care because the sooner you get the right drug into the patients, the sooner you will actually eliminate the microbe, and they'll be discharged more quickly, and it'll have a tremendous impact on our global healthcare bill.
Well, one of the things that's really important is as we anticipate a patient has an infection, while we're waiting for all these cultures to come back, we put them on oftentimes broad-spectrum antibiotic therapy. The less we have to use broad-spectrum drugs and can tailor the drugs to the infection the patient actually has, and with knowing what the profile of resistance or sensitivity of that bacteria or that microbe is, we don't have to treat with these broad-spectrum drugs right off the bat as much.
Yeah. Robin, the I in ICAAC stands for InterScience. Would you like to share with us how the program committee makes certain that we truly are reaching out to other disciplines beyond the traditional role of microbiology to really embrace our colleagues in these other emerging fields?
Right. Well, you know, we really can't do this alone. We can't do anything in medicine or in infectious disease alone. So we have a lot of different fields that are represented here. We have infectious disease, so the folks who are out seeing patients with infectious diseases in the clinics. We have microbiologists who are running clinical labs. We have research microbiologists, basic science microbiologists, and we also have people, very importantly, who are interested in pharmacokinetics and pharmacodynamics. So when you have a known antibiotic, what's the best way to deliver it to maximize your outcome and minimize your toxicity, and also to minimize the selection of resistance in the organism that you're treating and in all the other organisms that the patient might have. We are also very in touch with industry because we rely on industry to bring us new drugs, treatments, new diagnostics, and so forth that will change the way that we are able to manage patients and prevent, treat infections. And then, of course, if we can prevent things and never even have to see them anymore, you know, that's the ideal solution. And we can do that with, for example, vaccines. So that's really important to us as well. You know, as much as we love infectious disease, there are many we'd rather just not see at all. And
vaccines are the gold standard that we're all looking for.
Yeah, and there are a lot of changes that have occurred in our field as a result of vaccination, and there are a lot of changes that can occur in our field as a result of vaccination if we have some new vaccines that we can deploy into clinical practice.
One of the things that struck me that is one of my must-see is the single-dose drug candidate equal to a week of vancomycin. I mean, just imagine if you could only take one pill to get around taking a week of vancomycin. I mean, that's just got to be incredible, because many of the infectious disease practitioners know that vanc is the drug we look to when we have the poor patients who have MRSA. They're often seconded to go to vanc, and you know, it really disrupts their life, because you either have to be in a hospital or you have to go to an infusion center to really ensure that delivery is on board. So how did you guys highlight this particular abstract?
Well, so there's always been a lot of interest, I think, growing in the scientific community behind either shorter course therapy, what is the proper duration of therapy, and how can you do something innovative that would lessen the number of times you have to deliver a drug, all of which have strong implications for better patient care, decreased problems with toxicity. Just delivering medicines in the hospital or in a clinic have risk.
Oh, yes.
So, and the other thing is are we overtreating? And
Yeah.
overtreatment also has serious implications for resistance, et cetera, as well. So I think the other abstracts that we thought were quite interesting was one that did deal with shorter once daily treatment, and whether that was just as effective for acute skin and soft tissue infections, you know, in terms of 6-day therapy versus 10-day therapy and that kind of thing. So that one is a really interesting poster that I think is worth everybody attending to. It's interesting, as we teach in our academic lives, we're always touting that you treat certain things for 10 to 14 days, but then we get this interesting student who's inquisitive and says, well, why that period of time?
How do we come up with that number? I mean, I have the pleasure of teaching medical students, and they always play gotcha with you. And, you know, how did you figure out 7 days, 14 days,
Right.
or when you go to these longer course therapies for tuberculosis?
Mm-hmm.
And you really scratch your head, and a lot of it was empiric because it worked. And, you know, the basic science behind it is sort of still a black box to some extent.
Yeah, and I think that these two abstracts that we're talking about right now really start to address that sort of thing. And there are examples in the literature of there was one that got an award today that's also very interesting. And so I think that we're going to see more and more of these as we try and lessen the impact of antimicrobial use by using shorter therapy or fewer doses of therapy, as long as it's effective and works. So yeah, go ahead.
I was going to just ask, would either of you care to speculate on these new emerging diagnostic technologies where you literally blow into a tube and you can actually detect fungi, and whether or not you're infested with the fungi, and directing antimicrobial therapies towards that? I found that abstract just absolutely blew me away.
Yeah, so what these investigators did is they looked at Aspergillus, and Aspergillus is a very common and devastating cause of infection. It can be difficult to diagnose, as ID clinicians know, and so there's a lot of what we call empiric treatment that goes on for fungal infections. And part of the difficulty is that you really have to go in and take a biopsy in this day and age to really figure out what's going on. And you know, a lot of these patients are critically ill and you can't do that. But we know these organisms will emit volatile organic compounds, and we actually use those in the laboratory sometimes, at least in the old days before proteomics and genomics, to figure out what organism we were looking at. Well, these investigators have shown that patients who are infected with certain types of fungi actually breathe out those volatile organic compounds in their breath. And so they sampled breath from these patients and showed that you could use that to diagnose invasive aspergillosis. Wouldn't that be a great diagnostic?
I mean, it's absolutely incredible. Last week on TWIM, we discussed the microbiome of the armpit, of course, and everyone is familiar with underarm odor. And, you know, I was speculating before I did my homework for this. You know, this is truly the brave new world of being able to go after these things, because it's not invasive, it's very fast. And so this is the cutting edge of our discipline of how we're going to go. It almost is Star Trekian.
Exactly.
Of where you have the magic little tricorder of being able to detect things in real time.
Yeah, very exciting.
And we're already using it for things like Helicobacter pylori, which, you know, that was one of the great sort of strides towards diagnosis of patients with peptic ulcer disease and the potential contributions of Helicobacter. So I think you're going to see a lot more of this.
Yeah, and
It's
again, it's less invasive, it's less expensive once we get it to scale, and so I think, you know, it's really at the cutting edge, which is, you know, one of the highlights of ICAAC. And we're only have done Tuesday. We haven't even gotten to Wednesday yet.
Yeah, and if you're talking about cutting edge science, I mean, what these folks did is really show that it's possible. They don't have a diagnostic to deliver, but hopefully, you know, you take the science and you build it into a diagnostic and bring it to patients, and I mean, we can all understand how that can make a big difference.
And that's one of the other highlights of ICAAC is our industrial partners are here, and they are actually going through the science sessions and actually data mining, looking at where the cutting edge is, trying to build that next generation of stuff that the medical profession desperately needs. So what's next?
Well, C. difficile has been on the radar screen for quite a while now, and one of the big concerns is sort of highlighted here by a slide session that's occurring today on the incidence of C. diff infections in the hospital. And the unfortunate thing is that we've seen a near doubling now of C. diff infections in the hospital between 2001 and 10, and I would anticipate that it's still on the rise since 2010. So this one, I would really encourage people to take a look at that, because I think it's kind of where the kind of organism that we're going to be dealing with in the hospital on an ever-increasing basis we already are, and it's causing major problems and epidemics.
And it really adds substantially to the turnover rate in hospitals because of how deep you need to clean the room immediately after having a C. diff patient in there. The sorts of disinfectants that one has to use. People don't like the smelly hypochlorous smell associated with the bleaches that are typically used for this. They want the more pleasant smelling disinfectants. And of course, everyone is struggling with really preparing that room for the next patient so that it is indeed safe. So
yeah, and I think more importantly is it's a severe cause of mortality and morbidity amongst especially immunocompromised or patients who depend a lot on antibiotic and antimicrobial therapy. So how we can deal with this more effectively, understand its pathogenesis, I think is another critical aspect of what we need to do in the future.
okay, so now we move to the next day, Wednesday. If you're not exhausted, just wait until you get to Wednesday. Wednesday's chock-a-block full as well. And so, Robin, why don't you take us into Wednesday?
All right. Well, the first poster that we wanted to highlight is one on shingles vaccine coverage in elderly Americans. You know, this is a vaccine that works for older Americans, but unfortunately, this study tells us that not everybody's getting the shingles vaccine. It doesn't tell us why, but at least it gives us some data to indicate that not everyone's getting it. And so I think that provides some very helpful data and maybe something that people can work from to improve vaccination rates.
Yeah, when I looked at this particular abstract, when I was home this past Christmas visiting my father, then his next door neighbor came across the street and knocked on the door, and he described the symptoms associated with shingles. And I said, well, why didn't you get the vaccine? And he said, there's a vaccine? And so it really is one of these things where we have, you know, a tremendous opportunity to use a vaccine to actually decrease the occurrence of this amongst the people over 50.
Yeah, it can cause a lot of pain, shingles, and it can cause a lot of pain even after the acute episode, as you know. So it's a real problem.
Besides, I think it just indicates that seniors are as reluctant to get shots as infants.
Yeah.
Let me ask you, did you get yours yet?
No, because I'm not eligible yet.
Oh, really?
Fortunately.
Oh, okay.
I've been encouraging my physician to stick me, but she hasn't done it yet.
Okay.
She hasn't met a pill she didn't want to give me, but shots, not so much.
Okay, fair enough. The superbug, Acinetobacter, has been on the rise as a growing hospital-acquired pathogen for a long, long time. And one of the interesting things is how to manage Acinetobacter, not just in the patient, but in the hospital setting. And one of the problems with it is, as a water bug, is it doesn't take much to help it grow. But the other problem with it is it has a tendency to be very drug resistant. And this particular poster is showing us how disinfectant resistant it is as well. So standard disinfectants that we were using, oftentimes at what would be considered sublethal concentrations for this bug, are really showing to be problematic because we aren't getting rid of it in our disinfection routines.
So many of the lessons that we learned from the antibiotic world of sublethal concentrations of antimicrobials, taking your full bottle of pills, are coming home to roost with the Acinetobacter.
Yeah, and I think especially it's important when you're talking about patients that are going home with intravenous lines. They're managing those lines, and they're sent home with all the right stuff to do that, to care for the line, and also to instill their medications. So I think there's a lot of concern about how Acinetobacter is playing a larger and larger role.
Yeah, one of the things, I had the fortunate activity yesterday of lecturing to medical students, and I pointed out to them the only thing that bacteria like better than people are plastics. And they looked at me funny and thought I was half crazy, as always. And I said, no, seriously, you really have to appreciate the devices that you're placing into our patients to really worry about these things. And I think this Acinetobacter story is reflective of the creatures out in the environment are not out to get us. They're just out to make a living and get their own food
Take
stuff.
advantage of a new situation, right?
So the next abstract that we wanted to highlight is one on MRSA. You know, a lot of hospitals screen for MRSA when patients are admitted to the hospital. That's a controversial topic. But what they did in this paper is that they compared people who were colonized, known colonized with MRSA when they came in the hospital versus those who picked it up in the hospital because they were screening over time. And they looked at who was at risk for coming down with an actual MRSA infection, you know, something invasive. And it wasn't the ones who were necessarily colonized when they walked in the door, but the ones who picked it up in the hospital.
Oh, yeah.
Who were more likely to get infected. So
Yeah,
interesting data.
that whole area of screening, we do it at our hospital as course along with VRE. And everyone keeps asking the question, is it good value for money? And I always argue that it's cheap at twice the price. But, you know, the bean counters, of course, wonder.
Yeah, I'm sure your CFO hopped right onto that one.
Oh, yeah.
But I do think it's an interesting observation, as Robin pointed out, because it does imply that somebody who's chronically colonized with MRSA has somehow set up a sort of symbiotic relationship. And even when they come into the hospital for some reason, it doesn't predispose them necessarily to a more severe infection. But if you come in and acquire it, you're not used to carrying it, it means that's a whole new interaction. And so clearly this may be indicating from this study that you're at higher risk if you acquire it just
While you're
in the
admitted.
hospital. Yeah.
After all, you're going to the hospital because you're ill,
Yeah.
not because you're on vacation.
Yeah.
And it speaks to the need for good infection control in the
Yes,
hospital.
right.
Infection control is one of the things that we emphasize heavily at this meeting. It's very important for patient care so that our patients don't pick up these resistant organisms in our hospitals.
And you know, those folks are the unsung heroes. The CFOs are generally risk averse, but the infection control team is often shunned by everyone in the hospital because they're the ones out there arguing, wash your hands, and we need to do more with less.
Well, with the emphasis now on reducing cost to the hospital and reducing rates, and the fact that with the new healthcare reform going on, infection control has also all of a sudden risen to the top because they can help save money and keep patients from getting those secondary infections and complications for the original reason they were there, which keeps the hospital out of trouble financially. So
Yeah.
it's going to, I think it's changing.
And plus, we have to now worry about the people who come back within that magic window of 30 days.
Yeah, that's right.
And that's got every CFO scared. So then we move on to
We got one more
Okay.
on Wednesday that we were, actually a couple. One is just an interesting observation in Austria that sandflies are more widely distributed in Austria than they previously thought. And the time that they're there and can cause problems with biting is actually longer than they presumed. So this has really important ramifications for the potential emergence of a zoonotic related infection like leishmaniasis in a country that we don't normally think about having a problem with something like that.
Yeah, normally you think Leishmania is associated with subtropical beach-type environs.
Yeah.
And here everyone's first impression of Austria, of course, is from the Sound of Music with the Alps and the snow.
Right.
And here are we witnessing the consequences of climate change, or is it just somehow the pathogen has adapted with the insect vector to enable to move into a new habitat?
Very interesting question. We did want to highlight something that, Robin, do you want to tell them about the Cubist Award lecture?
Yes, so tomorrow afternoon, Wednesday afternoon at 1:30, we have the Cubist ICAAC Award lecture, and our speaker is Dr. George Dusano from the University of Florida. His talk is Suppression of Resistant Subpopulation Amplification, Pathogen Kill and Clinical Outcome, Relationship to Antimicrobial Exposure. And this is the topic I was highlighting before, where we have antibiotics and we need to administer them in the right way, at the right dose. Is it, IV, just you give them a drug, or you do continuous infusion? What's really the best way to treat that patient to maximize your response, minimize your toxicity? And so he's going to talk about that. He has just a whole career built around this area with over 250 publications in the area. So I would highly recommend that you attend his presentation.
Yeah, I always look forward to the Cubist Award lecture each year at ICAAC. It's always the high point of the conference, and I think this year's one actually looks especially exciting to listen to.
Yeah.
So that takes us now through Wednesday, and now we move on to Thursday. I mean, the week is just flying by, but the science just keeps getting better. So
This is Robin's
So I can
domain.
talk about this, because this is again on MALDI-TOF mass spectrometry in clinical microbiology. And I already told you that this is one of the new technologies that we have in the laboratory. So we have a whole symposium on this topic. So if you're not sure what it is, or you're not sure why I keep talking about the same thing over and over again, please do go to this symposium. You're going to hear about how it's used to identify bacteria, how it's used to identify fungi, how it works, and the changes that are going on in clinical microbiology laboratories as a result of this. So if you're interested at all in learning about this technology, this really is the session to go to.
I know it's on our top 10 list of capital equipment purchases for our hospital. We already have one. I think they want more.
Yeah, you do have to buy an instrument, that's right.
Yeah,
but
that's true.
but
But
it'll pay itself off pretty quickly.
Yeah, it really is a tremendous resource, and I think it's revolutionizing diagnostics almost the same way that PCR helped to revolutionize diagnostics.
Yeah, that's exactly right. I see it that way. And also, there are two major companies in the field. One of them just got their platform approved by the FDA last month, so that's exciting as well from a regulatory standpoint.
And more tremendous news.
So the next one really touches on an area that I'm not sure we've mentioned yet, and that is the ability to control the body's immune response to an infection, which we now know is critical in terms of severity of illness or not. In this particular case, it's looking at the role of one of the cytokines, interleukin 18, and a binding protein to cut back on IL-18's pro-inflammatory activity, so in response to a Pseudomonas infection. And so this was done in a mouse model, but there are other examples that are coming out that if you immunomodulate the host immune response during an infection, you can actually improve survival and morbidity and consequences. So this is a very interesting poster taking a look at a sort of new treatment for lung infection using a mouse model, though, where they showed improvement in survival significantly by just binding up some of the IL-18 that gets secreted and during the infection. And so this has really strong significance, not only for Pseudomonas infections like cystic fibrosis and sepsis due to Pseudomonas, but IL-18 is a major pro-inflammatory cytokine that basically is a respondent, an acute phase respondent to a lot of different types of infections. So I think we're going to see more and more of this. We're already seeing immunomodulatory therapy in the form of antibodies and other things to try and mitigate some of the inflammatory reactions that occur. And so I think that this is really exciting, really exciting work.
And I think the general public is really beginning to appreciate that inflammation is the evil And I think they're beginning to appreciate that, and they're beginning to have these conversations with their healthcare team about inflammation and how they can better control it. And so I think, you know, as young residents and fellows come and listen, they should really attend some of these cutting-edge immunology talks, because it will really give them that ability to interact with their patients as they're doing their Google searches, trying to play Stump the Doc.
Well, it's one of the reasons we have a pathogenesis category here, is because it's understanding that host-pathogen interaction, what tips the balance either in favor of the host or the microbe, is something that if we understand it better, the kind of complex and novel innovative therapies that Dr. Beccaro was talking about in his keynote address, that's where this is going to come into play, because it's not just about giving an antibiotic. And in fact, there's some bacterial infections where if you give the antibiotic, you really have to watch, because they actually worsen before they get better. And they can actually die on you even after you've given the antibiotic, because the lysis of the bacteria actually induces such an overwhelming inflammatory response. So I think that the way we learn how to modulate the host response in favor of making sure that the reaction to the microbe isn't too vigorous is probably going to be a big help.
And that's the cutting edge of medicine.
And that's the cutting edge of medicine, I think. Yeah.
Which takes us to this next topic, which I just think is absolutely fascinating. Vitamins and infectious disease.
Yeah.
I mean, this whole emerging field. Robin, why don't you take us to vitamin D?
Yeah, so this is kind of along the same lines,
Yeah.
right? So we have a terrible problem for kids, recurrent otitis media, and any parents out there who have kids who have recurrent ear
pulling on the ear.
infections, you know, they end up having to get antibiotics over and over again, and they can get tubes in their ears and so forth. Well, these investigators showed that by giving vitamin D supplements, you could prevent those recurrences. So isn't that exciting? There's a lot of literature out there on vitamin D and other infections, other bacterial and viral infections, but this one was specifically looking at recurrent otitis media, so recurrent ear infections.
I can see new clinical trials coming down the pike right now, asking a simple question, tubes versus vitamin D.
Yeah.
Just asking that simple question. And these investigators are laying that foundation to do some of these things, and to avoid an invasive process of putting in tubes versus something as simple.
Or giving antibiotics.
Or giving antibiotics. I mean, every parent who has a child in daycare immediately knows that if your child has a fever, it's no daycare for you,
Yeah.
and your life is disrupted. So I think, you know, this is really one of the must-see papers of the conference, is going to see what this vitamin Z story is about, and how to begin to ask the what's next question.
Correct, yeah.
Yeah, and one of those what next questions is being addressed by some other studies that are here, looking at how nutritional status actually influences your immune response to certain kinds of organisms. And I think that the more we learn there, that's going to guide even the kinds of statements that we make right now, which aren't necessarily based in a lot of science around nutrition. In fact, we're finding out that some of our recommendations may actually be toxic. So, you know, it's going to be a very important field of work, is to really look, especially, and this is very relevant in the developing world where nutritional status is always on the balance, or, you know, people are just nutritionally depleted incredibly. So what we learn about nutrition and how that benefits or impacts infections, I think is going to be really important.
Well, just consider the vitamin D story. We're now dipping our children in sunblock to prevent, you know, skin cancer, and dipping them in sunblock may not be as good, because, you know, you make vitamin D from the sun, and so as we begin, it's the trade-off of, do you need SPF, you know, 1,000 versus, you know, letting your kid out there to get some sun.
Well, or just making sure they get
the right supplement.
Fortified foods, right?
Yeah. And no ICAAC conference would be complete without addressing the ever-present problem of HIV and new therapies there. And of course, you're featuring one of the papers associated with that.
Sure, and one of the things that's really complicated to deal with, I mean, certainly one of the things that's made infectious disease work moving from an acute to a chronic disease kind of practice has been HIV. And if you couple that with cancer, you've really got some complicated patients to deal with, and it's really amazing. So this is a very interesting poster that takes a look at antiretroviral drugs in HIV patients who have cancer, and basically tries to address what is an effective antiretroviral in the face of chemotherapy that is not only safe but still allows for effective suppression of HIV. And so they came up with one drug that they thought, this inhibitor called raltegravir. I have a hard time saying that.
Raltegravir?
Raltegravir, thank you.
There's a special place in hell for
I
the chemists who name these things,
oh my God,
along with the taxonomists.
Yeah, I don't know
what's
what's gotten into these guys that make the HIV drugs, but they are tongue twisters for sure. But anyway, what was really interesting is the fact that they could actually tease out the best drug, safest drug to use in the face of chemotherapy with these very complex patients.
And that's just absolutely incredible. It's really, I think what we're beginning to see with these drug therapies is the beginning of personalized medicine. Everybody's talking about personalized medicine. Here we have witnessed a case of solid research that is really the frontier of personalized medicine. And as we begin to explore this whole issue of personalized medicine, our genome, the microbiome, and chemotherapy, we begin to witness how it's actually taking place in very unfortunate circumstance of HIV and cancer, but nevertheless, it is personalized medicine.
Good point.
And there's still more.
There's more on Thursday.
Good, there's more.
Busy day.
So another thing that you're going to see at this meeting is epidemiology studies.
Yes.
So there's a lot of different things that are covered by epidemiology studies. Some of them are small, single institutions. Some of them are multi-institutions. Some of them are from the government, from the CDC, or the WHO, and so forth. So just a couple of examples. One poster on in HIV-infected men, the association of erectile dysfunction drugs with syphilis. Interesting association. And then another epidemiology study on pertussis on the rise in the U.S. elderly. Whooping cough several years ago, we didn't even think hardly existed anymore because of the vaccine. We now know that there are outbreaks that are ongoing in kids, but this particular poster is looking at pertussis in the elderly. So lots of epidemiology studies to take a look at.
As a pediatrician, I can tell you the reservoir is adults.
Yeah, and
because they don't maintain their immunity. And what this just shows is that you continue to lose that immunity as you get older. And because as you get older, you're also interfacing with your grandkids. The challenge is how do you maintain your pertussis immunity so that they aren't infecting their kids?
And the answer is simply a boost. And when I talk about this, I ask, do you really want 100 days of a cough? And most people answer no, and they say, well, get yourself boosted. So.
And the other thing I think it's beginning to show us is that we need to do pertussis diagnostics in adult patients.
Yeah.
It's really critical.
And again, we're seeing the emergence of diagnostics, and we have good diagnostics for pertussis because it was so prevalent in our children. So Jim's given me the high sign that we have to
kind of move on.
Move on.
Okay, so there's a couple more that I think we are really hot on. One is aerosol delivery antibiotics for TB. That's worked in cystic fibrosis where we deliver antibiotics to keep down bacterial counts. The fact that they are now actually in this poster looking at eradication of 99% of bacteria in the lungs in a mouse model is really exciting as a potential for humans as well. So I think that's very exciting. One that makes a lot of sense is a slide session paper on single-dose HIV drugs and how it improves adherence and compliance to therapy. That's kind of an obvious one, but in fact it's important to prove that's true, and so they provide data on that. Using high-dose therapy in influenza outbreaks in contrast to standard doses is improving clearance. And so this is very interesting about what's happening in terms of high-dose therapy in flu patients.
One of the talks I'm most interested in hearing, of course, is the importance of the innovation in addressing infectious diseases in the developing world. And would you care to speculate how you were able to get a speaker for this extremely challenging topic?
Oh, lots of arm twisting, I think, is the best answer to that. No, in all seriousness, ICAAC is a very international meeting. I mean, in some ways, the I in ICAAC could stand for international. If you look at our attendees, over half of them come from outside of the U.S. But one area that we're trying to expand more, and this is an example of that, is the developing world, because infectious diseases, you know, are not, they don't stay within borders, and really, the field we work in is the whole world. And it is so important to address infectious diseases in the developing world. So I encourage people to come to Trevor Mundell's talk on Thursday at 1:30 on the importance of innovation in addressing infectious diseases in the developing world. You're right, we're really privileged to have him here, and I think it's going to be a fantastic presentation.
And he's representing an organization that basically was a game changer in the field of global
Yes.
health and funding for global health and infectious diseases and vaccines. So we like them to come every so often and tell us what they're doing, because it gives us a glimpse of, you know, what they're seeing coming down the road that they think is very important to invest in.
And also they can see where the cutting edge is, because the cutting edge is here. So hopefully they're wandering around checking out the posters that we just talked about and the other great talks.
Yeah.
And we're just up through Thursday, and then there's Friday morning, which concludes the conference, and there's 2 more papers there that you guys have selected for us to feature.
And so there are a couple of very interesting ones. One on decolonization. There's been a lot of interest in decolonizing patients, either as they come into the hospital in preparation for surgery or for other things. And in this study, they looked at patients colonized with gram-negative bacteria expressing ESBLs and active versus no decolonization activity. And they found that there was really no difference, and that approximately 50% become ESBL negative anyway after a year.
Yeah.
So maybe these efforts to decolonize maybe actually not doing much benefit to these patients.
And then finally, there's a diagnostic poster that we wanted to highlight on broad-range PCR in clinical management. So PCR, as you mentioned before, was really a revolution that happened in the 1990s and the early sort of turn of the century. But most of the time, the PCRs we use are for specific organisms, like pertussis, for example.
Right.
But there are technologies out there where you can do what's called broad-range PCR, so it can look for, quote-unquote, any bacteria or any fungus. That can be complicated by background noise from DNA from organisms that might be in your specimen or reagents, and we really don't understand necessarily how helpful that might be in clinical practice. But this is a really interesting poster because they looked at a large group of patients who had this kind of testing done, and they showed that it could have value in clinical practice. So I encourage people to go to this poster.
I mean, so many papers, so little time, and I think you have, both should be commended because you have put together a program second to none. And I think the attendees and those who are going to be able to download it if they get the ability to download it are really...
And they will.
They will.
Yeah.
They're in for a major treat, and they're going to have a good time.
Well, thanks for
Great.
letting us to come and talk to you about it and share our thoughts.
We'll take questions from the audience. We have a few minutes. Yes, sir, in the front row. And Jim's going to get you, please go to the microphone so we get it on the internet cast.
Thank you. It's Michael Smith, MedPage Today. Dr. Rubens, you were, I think, just about to discuss the one-shot treatment for skin infections versus 7 to 10 days of VANC. And I just wondered, 2 questions. One is, can you comment on the outcome of the 2 studies, the parallel Solo 1 and Solo 2 studies? And then secondly, I wanted to ask you a broader question about what appears to be from this meeting, the increasing range of options that are coming down the pipe for skin and soft tissue infections. So first Solo 1 and 2.
So basically, you know, what I know about this particular study is that these results basically showed that single-dose treatment with a drug called oritavancin is just as effective as 7 to 10 days of vancomycin. One of the challenges when we are picking these abstracts is we get to see the data 3 or 4 months in advance, but things change. So what I'm going to be hesitant to say is that the data is really solid until I'd actually get to go see this thing myself. But we thought that the principle of being able to give a single dose of a drug for a significant infection is really critical. I think we're going to learn more about this in terms of how we can do that for other types. There's been attempts with UTIs, for example, in women to be able to give a large dose of antibiotic one time, and they've looked at versus 3-day therapy. One of the interesting things about, at least that I understand about drug regulatory compliance, getting a new drug, is that there are certain types of infections that are easier to get through the FDA. This is not necessarily a good thing, but it's something that companies who develop these new drugs have to deal with. One of those is actually skin and soft tissue infections. And so it's easy, if the drug's appropriate, to get the regulatory okay to put your drug out on the market for skin and soft tissue. And so it's not uncommon to see a lot of these new drugs come out for that particular indication, and then they work hard to get other indications approved as they go down the line. So I'm not sure that addresses your question as well as you'd hoped, but I think that we see a lot of these new drugs coming out, some of the fluoroquinolones, some of the new beta-lactams, et cetera, because they can target those, show in studies very quickly that they're effective or not, and then it helps them get the drug out on the market faster.
And I think with oritavancin, the other issue is that it has a longer half-life. So you can give it once, but really you're giving it for a longer period of time than you would, say, if you were giving a single dose of vancomycin. So we have drugs that we can give less frequently, and that's advantageous, as was mentioned before, to patients because they don't have to come in as often, they don't have to have their line in place continuously, and yet if we can show they're effective, that's really a big advantage in terms of patient care.
It's all about risk mitigation.
Yeah.
Other questions? Okay, hearing none, we'll conclude this session of ICAAC Live, and again, you can follow us at #ICAAC, and please come back and join us for the other presentations here at ICAAC Live. We'll have one up in a few minutes. Thank you.
Thank you.
Explore the fundamental role of microbes in the natural history of our planet with Microbes in Evolution, the world that Darwin never saw. Available at estore.asm.org.